بسم الله الرحمن الرحيم. وصلنا إلى موضوع renal handling of sodium and potassium. بالنسبة للصوديوم excretion, the kidneys are essential for maintaining sodium balance, normally filtering about 21,000 millimole sodium per day through the glomeruli. إذن الكدنيز ضرورية للحفاظ على توازن الصوديوم، وعادة ما تقوم بترشيح حوالي 21,000 مليمول صوديوم في اليوم من خلال الجلوميرولاي. On a diet of 100 millimole sodium, and in the absence of any pathological loss of sodium, the kidney matches this intake with an excretion of 100 millimole sodium, which represents about 0.5% of the filtered sodium load. إذن في حالة نظام غذائي of 100 millimole of sodium، وفي حالة عدم وجود أي خسارة مرضية من الصوديوم، فالكلية راح تطابق هذا ال intake مع excretion of 100 millimole sodium، والذي يمثل حوالي 0.5% من filtered sodium load. As the GFR declines in chronic renal failure, the proportion of the filtered sodium that is excreted needs to increase progressively to maintain sodium balance. إذن مع انخفاض ال GFR في حالة ال chronic renal failure، فإن نسبة الصوديوم المفلترة التي excreted needs to increase progressively، تحتاج إلى زيادة تدريجية للحفاظ على توازن الصوديوم. The limit cannot generally exceed 20 to 30% of the filtered sodium load. إذن لا يمكن أن نتجاوز الحد عموما 20 إلى 30% من ال filtered sodium load. Once this is reached, any further reduction in GFR or an increase in dietary sodium leads to sodium mutation. بمجرد الوصول إلى ذلك، يؤدي أي انخفاض إضافي في ال GFR أو زيادة في الصوديوم الغذائي إلى احتباس الصوديوم. Most patients with chronic renal failure tolerate normal levels of dietary sodium if the GFR is more than 10 ml per minute. However, if the GFR falls below this level, sodium retention occurs, leading to expansion of the extracellular fluid, weight gain, and worsening hypertension. إذن يتحمل معظم المرضى الذين يعانون من الكرونيك رينال فيلير المستويات الطبيعية من الصوديوم الغذائي إذا كان ال GFR أكثر من 10 مل في الدقيقة. ومع ذلك إذا انخفض ال GFR إلى ما دون هذا المستوى، يحدث احتباس الصوديوم، مما يؤدي إلى الإكسبانشن في الإكستراسيلولار فلويد، زيادة في الوزن، وتفاقم ارتفاع ضغط الدم. In the presence of other sodium retaining states, example congestive cardiac failure or cirrhosis, sodium retention will be even more pronounced. إذن في حالة وجود حالات أخرى للصوديوم retaining، مثلا congestive cardiac failure or cirrhosis، الصوديوم retention يكون احتجاز الصوديوم أكثر وضوحا. Sodium retention will be even more pronounced. In chronic renal failure, excessive sodium loss may also occur. إذن في chronic renal failure قد تحدث أيضا خسارة مفرطة في الصوديوم. The capacity of the kidneys to adapt to changes in sodium intake is limited, and a requirement to conserve sodium, example in response to excessive use of diuretics or if the patient has severe diarrhea, may not be met by the damaged kidney. إذن قدرة الكدني على التكيف مع التغيرات في تناول الصوديوم تكون محدودة، ومتطلبات الحفاظ على الصوديوم على سبيل المثال استجابة لاستخدام المفرط لمدررات البول، أو إذا كان المريض يعاني من إسهال شديد قد لا تلبيها الكلى التالفة. This leads on to further fall in GFR، وهذا يؤدي إلى مزيد من الانخفاض في معدل ال GFR في fall in GFR. In chronic pyelonephritis and other disorders primarily affecting the renal tubules, large amounts of sodium may be lost in the urine, and severe sodium and water depletion can occur. إذن في التهاب chronic pyelonephritis and other disorders primarily affecting the renal tubules, كميات كبيرة من الصوديوم may be lost in the urine, and severe sodium and water depletion can occur. أما بالنسبة للبوتاسيوم excretion، about 90% of potassium in the glomerular filtrate is normally reabsorbed in the proximal tubules, the distal tubules regulating the amount of potassium excreted in the urine. The rate of secretion of potassium by the distal tubules is influenced by the transitubular potential by the tubular cell potassium concentration, and is usually maintained adequately provided the daily urine flow rate is greater than 1 liter، وعادة ما يتم الحفاظ عليه بشكل كافي بشرط أنه يكون ال daily urine flow rate أكثر من 1 liter. In the presence of normal GFR, about 550 millimole potassium is filtered daily at the glomerulus. إذن في حالة النورمال GFR فتقريبا 550 مليمول من البوتاسيوم is filtered daily يوميا at the glomerulus. An average daily intake of potassium is about 80 millimole per day, and external potassium balance is normally achieved by excretion about 15% of the filtered potassium. إذن external potassium balance normally achieved by excreting تقريبا 15% من الفلترد potassium. A reduction in the GFR، إذا قل ال GFR to about 10 ml per minute requires an increase in the proportion of the filtered potassium that excreted to 150%. إذن إذا قل ال GFR إلى تقريبا 10 ml per minute، فهذا requires زيادة بالproportion of filtered potassium that is excreted to 150%. Distal tubular secretion of potassium is needed to achieve this. Generally, the normal daily intake of potassium can be tolerated if the GFR is 10 ml per minute. At a GFR of about 5 ml per minute, however, the limit of adaptation is reached, leading to potassium retention and hyperkalemia. إذن في حالة ال GFR إذا صار about 5 ml per minute فال limit of adaptation is reached، يعني راح يوصل إلى حد التكيف راح يوصل، و leading to راح يؤدي إلى potassium retention، احتباس البوتاسيوم والهايبركاليميا at GFR of about 5 ml per minute. The ability of the GI tract to increase excretion of potassium helps to delay the onset of hyperkalemia. إذن قدرة الجاستروintestinal tract لزيادة الاكسكريشن of potassium تساعد حتى تأخر ال onset of hyperkalemia. In chronic renal disease, excessive renal losses of potassium are rare, but sodium depletion that sometimes develops in renal disease may be associated with secondary aldosteronism, which in turn causes excessive loss of potassium. إذن في حالة الكرونيك renal disease فال excessive renal losses للبوتاسيوم تكون شنو نادرة، ولكن the sodium depletion اللي في بعض الأحيان develops in renal disease may be associated with secondary aldosteronism, which in turn تسبب excessive loss of potassium. Measurement of urinary potassium output can prove helpful in patients suspected of losing abnormal amount of potassium. إذن قياس urinary potassium output can prove helpful في patients اللي suspected of losing abnormal amount of potassium. Persistence of relatively high urinary potassium output in the presence of hypokalemia strongly suggests that the kidneys is unable to conserve potassium adequately. إذن إذا ظل persistence of relatively نسبيا high urinary potassium output وفي وجود الهايبوكاليميا، يعني باليورين البوتاسيوم relatively high urinary potassium output وأكو hypokalemia في حالة وجود hypokalemia، فهذا strongly suggests that the kidney is unable to conserve potassium adequately. فهذا strongly suggests أنه الكدني غير قادرة على الحفاظ على البوتاسيوم بشكل كافي. الآن نأخذ موضوع Acute kidney injury. Acute kidney injury is a broad clinical syndrome of abrupt onset. إذن onset مالته يكون abrupt مفاجئ، due to intrinsic kidney diseases as well as pre-renal and post-renal causes. إذن الأسباب مالته قد تكون intrinsic kidney diseases، يعني بسبب أمراض داخلية في الكلى نفسها، بالإضافة إلى pre-renal و post-renal causes. It includes but is not restricted to acute renal failure. It is one of a number of acute kidney diseases and can coexist with other acute or chronic kidney diseases. The concept of acute kidney disorders is relatively new. إذا مفهوم acute kidney disorders نسبيا new جديد، and the definitions are evolving والتعاريف تتطور. the diagnosis of acute kidney injury تشخيص acute kidney injury والstaging of its severity are based on تعتمد على changes بالserum creatinine concentration and urine output. Acute kidney injury is defined by any of the following. إذن acute kidney injury يعرف by any of the following. Increase in serum creatinine by 26.5 micromole per liter or more within 48 hours. Increase in serum creatinine to 1.5 or more times baseline, which is known or presumed to have occurred within the previous 7 days. Urine output of less than 0.5 ml per kg per hour for 6 hours. إذن هذني ممكن أنه تكون تعريف لل acute kidney injury. Then acute kidney injury is defined يعرف by any of the following. قد يكون increase بالserum creatinine by 26.5 micromole per liter or more خلال 48 ساعة أو زيادة بالserum creatinine إلى 1.5 or more times the baseline, which is known or presumed to have occurred within the previous 7 days. Or urine output of less than 0.5 ml per kg per hour for 6 hours. Acute kidney failure is then a stage of acute kidney injury. إذن acute kidney failure هو a stage مرحلة من acute kidney injury defined by يعرف by GFR أقل من 15 ml per minute per 1.73 square meter body surface area, or the requirement for renal replacement therapy أو الحاجة إلى renal replacement therapy اللي قد تكون dialysis or transplantation. قد تكون غسل الكلى أو زرع الكلى. إذن acute kidney failure is then a stage of acute kidney injury defined by GFR يكون أقل من 15 ml per minute per 1.73 square meter body surface area, or الحاجة للrenal replacement therapy اللي قد تكون dialysis أو transplantation. By definition, this is a renal disease of acute onset severe enough to cause failure of renal homeostasis. إذن هذا acute kidney injury by definition هو شنو renal disease ويكون شنو acute onset ويكون شديد severe بما يكفي لأن يسبب failure of renal homeostasis. Often Oliguric و Diuretic و recovery phases can be recognized. Then there could be phases often Oliguric, Diuretic and recovery phases can be recognized, although a few patients maintain a normal urine output throughout the course of the illness. برغم من أنه a few patients يحافظون على normal urine output throughout the course of the illness. Chemical investigations help to determine the severity of the disease and to follow its course, but do not help much in determining the cause. إذن chemical investigation ساعد لتحديد severity of the disease و to follow a course لمتابعة الكورس مالت المرض، ولكن ما تساعد كثيرا في تحديد السبب. EGFR calculation are not valid غير صالحة in acute renal failure or when creatinine concentration is changing rapidly، أو عندما يكون تركيز الكرياتينين يتغير بسرعة. proteinuria is present والهيم pigment from blood may make the urine dark. بالنسبة للأوليجوريك phase، in this phase less than 400 ml of urine is produced each day. إذن في هذا الفيس أقل من 400 مل من اليورين ينتج كل يوم. إذا كان الرينال failure بسبب outflow obstruction ف there may be anuria. The oliguria is mainly due to a fallen GFR. إذن النقصان بالGFR هو السبب الرئيسي للأوليجوريا. The urine that is formed usually has an osmolality similar to plasma. إذن اليورين osmolality تكون عادة similar للبلازما osmolality and a relatively high sodium concentration. إذن هذا اليورين نسبيا تكون ب high sodium concentration. السبب أنه the composition of the small amount of glomerular filtrate produced is little altered by the damaged tubules. إذن تركيب هذا small amount of glomerular filtrate اللي ينتج little altered يتغير بشكل قليل بواسطة ال damaged tubules. Plasma sodium concentration is usually low due to a combination of factors including intake of water in excess of the amount able to be excreted. إذن يكون ال intake of water أكثر من الأماونت اللي ممكن أنه to be excreted. Increase in metabolic water from increased tissue catabolism وأيضا possibly a shift of sodium from extracellular fluid to intracellular fluid. إذن هذه الأسباب اللي ممكن أنه تؤدي إلى البلازما sodium concentration يصير low. بالنسبة للبلازما potassium concentration on the other hand is usually increased. إذن the plasma potassium concentration is usually increased. السبب شنو؟ due to impaired renal output and increased tissue catabolism, which is aggravated by the shift of potassium out of cells that accompanies the metabolic acidosis. إذن هناك حالة metabolic acidosis، وهذه الحالة metabolic acidosis راح يصير بيها shift of potassium out of cells. أما بالنسبة للmetabolic acidosis فهي develops شنو أسبابها؟ due to failure to excrete hydrogen and also due to increased formation of hydrogen from tissue catabolism. وأيضا يحدث هناك retention of urea, creatinine, phosphate, sulfate and other waste products occurs. The rate at which plasma urea concentration rises is affected by the rate of tissue catabolism. This in turn depends on the cause of acute renal failure. In renal failure due to trauma، إذا كان renal failure بسبب trauma including تشمل مثلا renal failure developing after surgical operations plasma urea concentration tends to rise more rapidly. إذا البلازما urea concentration يميل أنه يزداد بشكل أسرع من in patients with renal failure due to medical causes such as acute glomerulonephritis. To differentiate the low urinary output of suspected acute renal failure from that due to severe circulatory impairment with reduced blood volume, the test summarized in table 4.4. إذن للتمييز low urinary output of suspected acute renal failure من low urinary output اللي سببه severe circulatory impairment with reduced blood volume، فهناك test وموجودة في هذا التيبل 4.4. هذا التيبل ب investigations of low urinary output، وهنا في هذا العمود الأول نعطينا investigations التحاليل اللي نسويها، وفي العمود الثاني نعطينا simple hypovolemia، والعمود الثالث acute renal failure. فإذا هذا الجدول هو للتفريق ما بين حالة simple hypovolemia والacute renal failure، لأن في الحالتين ممكن أن يحدث low urinary output. فشلون نفرق أنه هذا بسبب كان hypovolemia أو كان بسبب acute renal failure؟ فهناك مجموعة من الانفستيجيشنز ممكن أنه تفيد بهذا الموضوع. فبالنسبة للurine osmolality بالsimple hypovolemia usually more than 500 millimole per kg، أما في acute renal failure usually أقل من 400 millimole per kg. بالنسبة للurine urea concentration إلى البلازما urea concentration، هذه النسبة ما بين الurine urea concentration إلى البلازما urea concentration بالحالة simple hypovolemia usually more than 10 أكثر من 10، أما في حالة acute renal failure usually أقل من 5. أما بالنسبة للurine sodium concentration ففي simple hypovolemia usually أقل من 20 millimole per liter، في حين في acute renal failure usually more than 40 millimole per liter. إذن مثل ما شفنا أنه هاي التست اللي summarized in table 4.4 may be helpful، ربما تكون مفيدة لل differentiation between low urinary output of suspected acute renal failure from that due to severe circulatory impairment with reduced blood volume. However, ومع ذلك, none of these tests can be completely relied upon. إذن ومع ذلك none of these tests ممكن أنه completely يعتمد عليه to make an important and urgent distinction between renal failure and hypovolemia. Careful assessment of patients' fluid status, possibly include measurement of the central venous pressure, is also required. For monitoring patients in the oliguric phase of acute renal failure, the plasma creatinine concentration or urea concentration and the plasma potassium concentration are particularly important and need to be determined at least once daily. إذن monitoring للpatient اللي في oliguric phase of acute renal failure فالبلازما creatinine concentration or urea concentration والبلازما potassium concentrations are particularly important، مهمة بشكل خاص and need to be determined، تحتاج أنه تحدد at least daily على الأقل يوميا. Decisions to use hemodialysis are reached at least partly on the basis of the result of these tests. إذن decisions to use hemodialysis are reached at least على الأقل partly جزئيا on the basis of the results of these tests. The volume of urine and its electrolyte composition and the volume and composition of any other measurable sources of fluid loss should also be assessed in order to determine fluid and electrolyte replacement requirements. إذن حجم اليورين و its electrolyte composition وأيضا حجم والcomposition of any other measurable sources of fluid loss should also be assessed in order to determine تحديد fluid and electrolyte replacement requirements.
بالنسبة للdiuretic phase, with the onset of this phase, the urine volume increases, but the clearance of urea, creatinine, and other waste products may not improve to the same extent. Plasma urea concentration and creatinine concentration may therefore continue to rise, at least at the start of the diuretic phase. إذن مع بداية هذا الdiuretic phase فحجم اليورين increases, but the clearance of urea, creatinine, and other waste products may not improve to the same extent. ولهذا the plasma urea concentration and creatinine concentration may therefore continue to rise على الأقل at the start of the diuretic phase. Large losses of electrolytes may occur in the urine and require to be replaced orally or parenterally. Measurement of these losses is needed so that correct replacement therapy can be given. This requires urine collections for urine sodium concentration and potassium concentration measurements and calculation of daily outputs. إذن خسائر كبيرة في الإلكترولايتس ربما تحدث in the urine وتحتاج أنه تعوض orally or parenterally. قياس هذه الخسائر is needed so that correct replacement therapy can be given. This requires urine collection for urine sodium concentration and potassium concentration measurements and calculation of daily outputs. Plasma potassium concentration tends to fall as the diuretic phase continues due to the shift of potassium back into the cells and to marked losses in urine resulting from impaired conservation of potassium by the still damaged tubules. إذن البلازما potassium concentration يميل إلى ينخفض as the diuretic phase continues due to the shift of potassium back into the cells and to marked losses في الurine resulting from impaired conservation of potassium by the still damaged tubules. وأيضا الخسائر الملحوظة في اليورين الناتجة بسبب impaired conservation of potassium by the still damaged tubules بسبب الtubules اللي لا تزال damaged. Usually, sodium deficiency also occurs due to failure of renal conservation. عادة نقص في الصوديوم أيضا يحدث due to failure of renal conservation بسبب فشل الحفظ الكلوي. Throughout the diuretic phase, therefore, it is important to measure plasma creatinine concentration and both plasma sodium and potassium concentrations at least once daily, and to monitor the output of sodium and potassium in the urine. إذن throughout the diuretic phase therefore من المهم قياس البلازما creatinine concentration وكلا البلازما sodium concentration والpotassium concentration على الأقل once daily, and to monitor the output of sodium and potassium in the urine. الآن نأخذ موضوع chronic kidney disease. Most of the functional changes seen in chronic renal impairment can be explained ممكن أن تفسر in terms of full solute load falling on a reduced number of normal nephrons. إذن هذا الفول solute load يقع على reduced number من normal nephrons. The GFR is invariably reduced, associated with retention of urea, creatinine, urate, various phenolic and indolic acids, and other organic substances. The progress and severity of the disease are usually monitored by measuring plasma creatinine concentration and urea concentration and by calculating the eGFR. Chronic kidney disease affects up to 10% of the population and is often asymptomatic until renal function is severely reduced. Furthermore, mild chronic kidney disease is a significant risk factor for cardiovascular disease. إذن mild chronic kidney disease هو عامل خطورة مهم significant for cardiovascular disease. Detection of asymptomatic progressive CKD could allow patients to be actively treated and to preserve renal function and reduce cardiovascular risk. إذن اكتشاف الاسيمتوماتيك progressive CKD ممكن انه allow patients انه to be actively treated يعالجون للحفاظ على renal function and reduce cardiovascular risk. The creatinine concentration gives an indication of GFR and is readily performed but can be misleading. إذا الكرياتين concentration هو gives an indication لل GFR و readily performed ولكن ممكن أن يكون misleading. وخصوصا in particular creatinine concentration is influenced by muscle mass. إذا الكرياتين concentration يتأثر بالmuscle mass and hence by sex and age as well as بالإضافة by GFR. مثلا a small elderly woman could lose a large proportion of her GFR and still have a creatinine concentration within the population reference range and less than that of a young, more muscular man. ولهذا, so a normal creatinine concentration can be misleading in such a patient. By incorporating the age and sex into its calculation, the eGFR circumvents these problems, although it is not always applicable. إذن by incorporating the age and sex بالcalculation مالت eGFR فبهذه الحالة ممكن إنه circumvent جاوز هذه المشاكل بالرغم أنه it's not always applicable. eGFR is the basis for detection and the classification of CKD كما في هذا التيبل 4.5 اللي هو بيه classification of CKD وهنا نشوفون stages 5 stages وهنا لكل stage eGFR اللي هو بالمل per minute per 1.73 square meter وهنا description لكل stage والتريتمنت. فبالنسبة مثلا stage 1 فهنا eGFR 90 plus description معناتها high normal kidney function treatment stage observation control blood pressure. بالنسبة للstage 2 هنا eGFR ما بين 60 إلى 89 هنا description معناتها high stage هي mildly impaired kidney function. The treatment stage observation, control blood pressure and risk factors. بالنسبة للستيج 3 هنا ال EGFR ما بين 30 إلى 59. high stage هي moderately impaired kidney function. treatment stage معناتها observation, control blood pressure and risk factors. stage 4 هنا ال EGFR ما بين 15 إلى 29. هنا حتكون severely impaired kidney function. وال treatment stage معناتها planning for end stage renal failure. و stage 5 ال EGFR معناتها أقل من 15. هنا ال description مال high stage هي established kidney failure. وال treatment stage هي treatment choices for renal replacement therapy. هنا ملاحظة على stage 1 و stage 2. In addition to EGFR results, the diagnosis of stage 1 or 2 CKD requires a structural abnormalities of the kidney, مثلا polycystic kidney disease, or a functional abnormality such as persistent proteinuria or hematuria. In the absence of these, an EGFR between 60 and 89 is not abnormal. فإذا هذا التابل هو بالclassification مالت ال CKD. وهنا it should be emphasized that an EGFR الأكثر من 60 ml per minute per 1.73 square meter should be regarded as normal in the absence of any other indications of kidney disease. إذن مثل ما قلنا إنه ال EGFR اللي أكثر من 60 ml per minute per 1.73 square meter يجب أن يعتبر normal في غياب any other indication of kidney disease. This can be وهذا ممكن أن يكون structural كما في polycystic kidney disease على سبيل المثال, or a urine abnormality such as proteinuria or hematuria. بالنسبة للصوديوم, potassium and water, فالrenal handling of sodium with potassium and water by normal kidneys and in chronic renal failure has already been considered above. أما بالنسبة للacid-base disturbances, the total excretion of hydrogen is impaired, mainly due to a fall in the renal capacity to form ammonium in NH4. Metabolic acidosis is present in most patients, but its severity remains fairly stable in spite of reduced urinary hydrogen excretion. There may be an extrarenal mechanism for hydrogen elimination. إذن هناك احتمال ميكانيكية extrarenal خارج الكدني للhydrogen elimination, possibly محتملا تكون involving buffering of hydrogen by calcium salts in bone في العظم. This would contribute to the demineralization of bone that often occurs in chronic kidney disease. إذن هذا احتمال أنه contribute لحالة demineralization في البون اللي تصير في chronic kidney disease. الكالسيوم and phosphate. فالكالسيوم plasma calcium concentration tends to be low, يميل أنه يكون low, often due at least partly to reduced plasma albumin concentration. إذن غالبا بسبب على الأقل جزئيا بسبب reduced plasma albumin concentration. أما بالنسبة للبلازما phosphate concentration is high, mainly due to the reduction of GFR. إذن the plasma calcium concentration tends to be low, the plasma phosphate concentration is high. Virtually all patients with the later stages of chronic kidney disease have secondary or much less often tertiary hyperparathyroidism. إذن تقريبا كل البيشنت في الحالات في المراحل المتأخرة من الكرونيك كدني ديزيز يصير عندهم secondary أو much less often tertiary hyperparathyroidism, and they may develop حالة osteoitis fibrosa. The plasma calcium concentration, which is decreased or close to lower reference value in patients with secondary hyperparathyroidism, increases later if tertiary hyperparathyroidism develops. إذن the plasma calcium concentration اللي يكون قليل أو close to the lower reference value في المرضى اللي عندهم secondary hyperparathyroidism يزيد بعدين إذا tertiary hyperparathyroidism develops. Many patients with a low plasma calcium concentration have reduced activity of renal cholecalciferol 1 alpha hydroxylase. اللي هو شنو هذا الانزيم responsible for the synthesis of most active form of vitamin D. فإذن many patients اللي عندهم low plasma calcium concentration يصير عندهم يكون عندهم have reduced activity للrenal cholecalciferol 1 alpha hydroxylase. They can potentially develop osteomalacia or rickets, but this would be uncommon in adequately treated patients. A few patients show a third type of bone abnormality اللي هي increased bone density أو osteosclerosis. It is not clear why any particular one of these various types of renal osteodystrophy should develop in an individual patient. إذن هذا ما يخص الكالسيوم والفوسفات في حالة المرضى اللي عندهم chronic kidney disease. Other laboratory abnormalities في المرضى اللي عندهم chronic kidney disease, other findings in chronic kidney disease may include impaired glucose tolerance and raised plasma magnesium concentration. These may need appropriate treatment but are of no particular diagnostic significance. وأيضا احتمال يصير عندهم أنيميا السبب أنه يصير impaired renal erythropoietin synthesis, وهذا contributes to the anemia, which is often present in patients with a chronic kidney disease. Biosynthetic erythropoietin can be used to treat this. فإذن هذني الابنورماليتيز اللي تصير في البيشنتس اللي عندهم chronic kidney disease.